Hmm. All right, good morning, everyone. I'm sorry for the snafus. So we've got Zoom going today, but it turns out our soccer players have an early morning practice. And then Kylie caught what her brother uh, has, so she's sick. So it's just kind of a comedy of errors today. We've got one thing after another, it seems, working against us. We got the building that's not open. We've got just all kinds of rubbish. But that's not going to stop us. You know, the old saying, rain or sleet or snow or doom of night or, whatever, or something like that. Okay, did you give it a try? Anybody on? No, nobody's on. Okay, it's recording. We're going to go ahead and get started. Hope your Thanksgiving was all you hoped it to be. We even got some rain and some snow. All that white stuff out there looks rather pretty. And yeah, there we are. Okay, we are talking about let me get this so that, there, share the screen. Okay, there we are. Good, 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 good. Okay, infections of the central nervous system. Let's pray, then we'll have more to say. Lord, we do thank you. We thank you for a week off. We want to pray for our colleagues in Alabama. Their weather's much nicer than ours is here, but we have the white snow. Watch over them, please. Help them to stay healthy, help them to play really well. We pray particularly for Emma. She's trying to heal from a pretty devastating injury. She probably really wants to be on the pitch with her friends instead of warming a seat on the bench, as it would be. So watch over them. We also pray for those of our colleagues who are sick. Please heal them. Now, Lord, even though with locked doors and what have you, help us to concentrate on the subject at hand. In Jesus' name, amen. So your brain and spinal cord are protected by these three different layers. And the Merck manual has a very nice little 3D graphic here that shows you this. Okay, stop share. And then I need to share that. That's the issue with Zoom. You have to keep going back and forth between these. So we can see here that we have the bone. So if this is your brain, then that's your skull. If this is your spinal cord, that would be the vertebral column. So this would be a vertebra or something like that. Right up against that bone, you have the dura mater. This is hard, this is fibrous, this is tough. This is almost in some ways an extension of the bone, but it's not calcified, but it's very, very tough, very fibrous. When you guys dissected your cats, I don't know how much you got into the skull, if you got to take the skull cap off or anything like that. The dura, when you pull that off, pretty much sits on the skull. Then there's that spidey webby stuff. When you take the bone saw, go around the cat. You guys are looking at me as if to say we did that in anatomy. Did you guys get into the skull of the cat at all? No. Well, if you had taken a bone saw and gone around the head of the cat and then pulled the skull cap off, you have this spider webby stuff that would stick to it. The dura would be stuck if you, in fact, take the skull and scrape it with your fingernail. there'd be this fibrous stuff, that's the dura. The spider webby stuff is this arachnoid matter here. And the arachnoid matter, as you can see, that's the area where the cerebrospinal fluid is kept. And you can see you have your arteries and your veins in this arachnoid, subarachnoid space. And these spider webby supports, that's the arachnoid matter. When you have meningitis, this area tends to be infected, and because it can affect the ability of the veins to properly drain spinal fluid, it can affect the pressure, the cerebrospinal fluid pressure. Also, this increased pressure can press on the arteries. Yeah.
When you're talking about cranial pressure, like, I don't know exactly what it's called, but cranial something pressure.
Intracranial pressure.
Yeah. Are you talking about the pressure within the arachnoid?
Yeah, pretty much. Yeah. Pretty much. Because that's where the CSF really is found. So yes.
So if somebody has, what is it, hydrocephalus, I think it's called something like that, they get in arachnoid matter.
It's this pressure here. Exactly. Exactly. The pia-mater, as you can see, is cellular and fibrous. It is much more flexible and fragile than the dura, not nearly as thick as the dura as well. Altogether, the pia-mater, arachnoid mater, dura mater make the meninges. Meningitis refers to infection of the meninges. If you infect the parenchyma of the brain, that's an encephalitis. If you infect both the meninges and the brain parenchyma, that's a meningoencephalitis. Meningoencephalitis. Bacterial infections will usually cause meningitis. There are cases where they can cause meningoencephalitis, but it's usually meningitis. A pure encephalitis is almost always viral. Almost always viral. Parasite infections can do both. Certain fungal infections can do both as well. Your bacteria usually are going to be meningitis predominantly. So when we say meningitis, this is the area to which we're referring. Irritation in this area, inflammation in this area, we have increased white cells and things like that, will inflame certain nerves. Because it inflames certain nerves, there are certain signs that you will see. Let's look at a couple of these signs. So I have to stop the share here, and I have to, no. I have to go here, and I have to go here. Then I have to do share. Zoom. All right, so I have to go here and share. All right. All right, this is called a Kernig sign. When you hear Kernig sign, think K, think knee. K. With a Kernig sign, you're going to take the knee, you're going to flex it. And now, normally when you do that to someone, they'll say, oh, my hamstrings hurt. But if the spine hurts, that's a sign that you have inflammation of the meninges. This is not specific to meningitis, but it's a pretty good indication you've got something inflammatory going on in the meninges. So this is a Kernig sign, and I need to plug in the speaker here. You all can hear it. Make sure this is cranked. Okay. Kernig sign, this guy's got a little bit of an accent, so. Stretch. Next line, please. Koenig knee, K knee, Koenig knee. That's the knee sign. Now the other sign is a Brzezinski sign. The Brzezinski sign. I have to stop and then I have to go back here. This is a little more specific than a Koenig sign, but they kind of go together. They kind of go together. So Brzezinski sign, B, think bend, bend the neck, bend the neck. So here's a Brzezinski sign. See the knees go up there? It can be subtle. You can miss this. So as you're flexing the neck, you need to watch the knee. And sometimes it could be a twitch of the hips too. It can be subtle. So this can be easy to miss. You have to be careful.
Holiday season. Espresso is out in pastries, entrancing alcohol world.
That's about that stuff there. All right. So let's turn off. Okay, so now I have to stop the share, go back, and yep, that's what. There we go. All right. So when you irritate the meninges, you will irritate nerves. You irritate nerves, you can get some of these various types of signs. Koenig and Brzezinski signs are not specific to meningitis, but they're a pretty good sign. You've got something hinky going on in the meninges, usually something inflammatory in nature. The other three signs we talked about with meningitis are going to be headache, fever, and nuchal rigidity. Nuchal rigidity is not seen with pure encephalitis. Nuchal rigidity is very specific to meningitis. Meningitis. And then photophobia is the other main sign that you may see, where lights, they really don't like the lights. And like, you know, in the morning, when you get up in the morning, you turn the light on. No. That doesn't mean you have meningitis, it just means you're not a morning person. In fact, one of the things you do with a head to toe exam is you examine the ocular reflex, and just shining the light in their eyes can make them wince. No, don't do that. Now, granted, when I get my eyes checked every year and they dilate your eye and they say, okay, look at the light, and I just tell them it's not happening. No, that's painful. It's not happening. That doesn't mean I have meningitis, but usually, and if it's a wincing, it's ooh, no, oh, that doesn't do it. It's far beyond the normal reaction you get to shining a light in the eyes to see if you get a pupil response. So those are your main clinical signs with meningitis. So remember, the cerebrospinal fluid circulates. It's made by the choroid plexi. Those cells that make it, that's the blood-brain barrier. Meningitis is going to vary according to causes of meningitis. It will vary according to age. So here is this. Some of the various causes. Depending on the age of the patient, that will usually give you a pretty good idea of the possibilities. All right, so since the brain is immunologically privileged, the ability to cause meningitis depends on the organism's ability to cross that blood-brain barrier. Organisms have different ways they can cross through that barrier. So if we look, for example, at our little sheet here, so group B streptococci are usually only a problem in neonates and young infants meaning that they're anywhere from just having been born to about 3 months old. Haven't been born to 3 months old. Remember, group B strep, Streptococcus agalactiae that we looked at in the lab, well, now 2 weeks ago. That is a denizen in some women of the birth canal and of the female urogenital tract. You're going to take the mother and you're going to do a vaginal swab for group B strep. If she has group B strep, you will treat her prophylactically with antibiotics. If you don't, and the baby gets infected, you can have premature rupture of the membranes of the amnion, so premature labor. Premature babies, as you guys will discover in your L&D, your labor and delivery rotation, are subject to greater chances of having respiratory issues and other types of neurological issues and just issues in general. These group B strep can also cause meningitis. The blood-brain barrier in babies is not completely formed. So this infection usually will cause, in many cases, pneumonia, and then through hematogenous spread, it gets to the brain. Fortunately, group B strep is very treatable with beta-lactam antibiotics. But if you screen the mother, pre-treat the mother, you can avoid this. But if the mom did not have any prenatal care, say she just had a home birth and the midwife didn't pre-swab her or something like that, or siblings also had trouble or something like that, that's gonna your spidey sense is gonna start tingling with strep. And again, very treatable. E. coli. E. coli is also one of the major causes of a very nasty meningitis in neonates. Now, E. coli causes UTIs, and because of the anatomical proximity between the birth canal and the urethra in mothers, E. coli can also infect the birth canal, and it can infect the kid as the kid gets born and cause meningitis. Fortunately, if mom has had her UTI properly treated, this usually doesn't happen. So there's a hygiene thing going on here as well. Listeria monocytogenes passes from the mom through the placenta. So there are these groups of organisms, they are recognized by the acronym TORCH. And this one falls under others. So this would be Listeria monocytogenes. And also syphilis. And the rest of these also be toxoplasma, which we'll talk about hopefully today. Rubella, cytomegalovirus, and this is going to be HSV. Either one or two, usually. So those others, Listeria, treponema. Now, Listeria, you acquire through contaminated food, usually dairy or deli meats. Those are definitely the two most common places where you'll pick up listeria. So if the mom has this diarrheal disease that really wasn't of any consequence to her, but the organism can pass placenta and infect the baby can be born with listeria. And this listeria are resistant to cephalosporins. You have to treat with ampicillin. Ampicillin will treat listeria. Cephalosporins will not. So many people see an organism, they say, oh, we'll just use ceftriaxone, or they get a gram-positive organism. Oh, we'll just use ceftriaxone. Well, ceftriaxone, good drug, but it's not going to treat listeria. It's resistant to cephalosporins, so you have to use ampicillins. In older infants, children, and even young adults, now the big organism here will be Streptococcus pneumoniae. So Strep pneumoniae usually causes either otitis media, sinusitis, or sometimes bronchopneumonia first. Then through hematogenous spread, it's able to penetrate the blood-brain barrier and cause meningitis. So usually, with Strep pneumoniae, there was a previous upper respiratory infection or ear infection. Strep pneumoniae has a capsule. That capsule is antiphagocytic. So if you have a patient without a spleen, this organism will be particularly hard to kill, because in order to properly phagocytize the organism and kill it, you need opsonizing antibodies. Where do you get those big clusters of B cells that will make those opsonizing antibodies? In the spleen. So without a spleen, people will be more susceptible to infection by encapsulated organisms. Same song, second verse for Neisseria meningitidis. Now, Neisseria meningitidis penetrates a cribriform plate and causes infection. It usually does not cause an upper respiratory infection. So, a little story, I was on a mission trip to Mexico. We're building a church building. And we got word, we got up early to start putting doorways and stuff like that. We heard that one of the ladies in the church, her baby had died during the night. Completely healthy, and then just all of a sudden died. And my one of my colleagues who was on a mission trip, they looked at me and said, what could kill a kid that fast? And I said, probably Neisseria meningitidis. Like we said, isn't there a vaccine for that? I said, yeah, but it's not given very much down here in Mexico. Once you know the kid was sick, I said, not necessarily. Had a slight fever. Maybe didn't eat quite as much, but the symptoms can be pretty subtle. That he died during the night. There was no autopsy, but if I was a betting person, which I'm not, I would have bet that the kid died of Neisseria meningitidis. Yes, it can kill that quickly. We had a funeral for the little guy the very next day in the church building that was almost completed. And we buried him. It's very sad. But anyway, that's an example of an organism that can actually work pretty quickly. Now, Haemophilus influenzae, because of the Hep B vaccine, not much of a problem in this country. However, we're seeing lots of mass immigration into this country from third world countries where they don't vaccinate kids on a regular basis. Also, more and more people are not vaccinating their children. So while it's easy to look at this organism and write it off, say, oh, you're just not going to see that much, you're going to start seeing it now. All of these organisms here, they're encapsulated. They have polysaccharide capsules that cause it to resist phagocytosis. Now, Haemophilus can also cause epiglottitis, which we'll talk about when we get to upper respiratory infections. Epiglottitis can cause viral epiglottitis, can usually cause croup. Bacterial epiglottitis is a medical emergency. That thing can swell up so much it can actually block off the airway. And the child will need to be intubated. So there are also versions of this organism that are not encapsulated. They're called untypable Haemophilus influenzae. So while in your practice, most of your kids will not have Haemophilus infections, you may get immigrant kids, you may get kids whose parents don't vaccinate them. You have meningitis with Haemophilus influenzae. It can't happen. Once you get out of young adulthood, and the cutoff point here would be about 18, 19 years of age. So between 17 and 19 years of age. 3 biggies then are going to be Staphylococcus pneumoniae, Staphylococcus aureus, and Neisseria meningitidis. Staph aureus will usually be the case if someone has had some sort of trauma to the head. They have had any sort of penetrating injury, car accident, blow to the head, something like that. It's usually going to be Staph aureus. That will be the issue. Neisseria, you can get vaccinated against those. Neisseria, unfortunately, because they're faster respiratory droplets, can spread very quickly in close quarters. In older adults, it's usually strep pneumoniae. If someone comes in, they have meningitis, and they're older, it's strep pneumoniae. The other place where you see strep pneumoniae really often is in alcoholics. Staph aureus, if it is part of a penetrating head wound, and Listeria monocytogenes, if they are part of that group that has eaten contaminated dairy or something like that. So my wife's dad was a milker. My wife is Dutch, very Dutch. And her dad was a professional milker, and he used to bring home raw milk. And my wife said, well, we used to drink it all the time, and we were fine. Had a good idea. No. We were fine when you were lucky, is what you were. Because this organism can be found in contaminated dairy. So can several other organisms, like salmonella and others. So don't drink raw milk. Don't drink raw milk. And if you have patients, clients who drink raw milk, try to dissuade them from doing so. And especially dissuade them from feeding it to their kids. Lots of great ways to get infections. All right. Moving on. Brain, it seems, does not have a normal biota. So we'll just go from there. All right. Talk about that. Now, there are certain signs and symptoms that will be peculiar to certain types of meningitis. Several viral meningitises can cause skin rashes. However, there are certain skin rashes you need to be aware of. So Neisseria meningitidis will tend to slough capsule and cell wall material into the blood that material will tend to get stuck in capillaries in the skin and cause local inflammation, and you get this big, splotchy, grayish rash when you have a Neisseria meningitidis infection. So if you have a big splotchy rash, that big splotchy rash tells you it's Neisseria meningitidis. Several viral meningitises can also cause rashes. They're usually maculopapular. So, for example, West Nile virus can cause a rash. It is very different than the rash you get with Neisseria meningitidis. In fact, amongst the bacteria, Neisseria meningitidis rash is diagnostic usually for Neisseria meningitidis. Or bacterial meningitis. And usually bacterial meningitis is very fulminant. Whereas a viral meningitis tends to come on kind of quickly, but it's usually not terribly severe, and it tends to resolve on its own. Bacterial meningitis are very fulminant, give very high fever, and the patient has really robust symptoms. In this case, usually, drawing cerebrospinal fluid, gram staining it, and finding the organism usually tells you what you have. So with Neisseria meningitidis, you'll see gram-negative diplococci. Streptococcus pneumoniae, you see gram-positive. Diplococci, that instead of nice round cells, they're kind of squished a little. They're kind of lancet shaped. Haemophilus influenzae, you see very short rods that don't form chains or anything like that by themselves. Staph aureus, of course, you see great like clusters of round gram-positive cocci. Group B streptococci, gram-positive, short chains of cells. But what if you gram stain the CSF and you don't see anything? That is called an aseptic meningitis. An aseptic meningitis. It does not mean there's nothing there. It just means you can't see it. Now, why might the cerebrospinal fluid be devoid of bacteria? Any guesses? Iris's gram stain? No. How about fungi? Do fungi gram stain? No. So it's something other than a bacterium that is causing the infection. Since it's something other than a bacterium that's causing the infection, you're not going to see the bacteria, are you? So, if you sample the CSF and you don't see something, it means something other than a bacterium is causing the infection. So in the cerebrospinal fluid, if you see lots of protein and lots of neutrophils, That usually tells you it's a bacterial infection. CSF usually does not have a lot of cells in it. If you have maybe slightly increased protein, and you see mainly lymphocytes. So protein might be but you see lymphocytes. That tells you it's viral. The other thing you'll see if it's bacterial, your glucose levels in your CSF will be low. Simply due to the fact that both the bacteria and the white cells are chewing up the glucose. What if you have increased protein, but you see mainly monocytes? In this case, it could be either fungi or it could be tuberculosis. We'll talk more about tuberculosis when we talk about respiratory infections, but when tuberculosis disseminates from the lungs, one of the places it can go is the brain. If your gram stain is negative, one of the other things you can do is an India ink stain. Because one of the fungi that causes meningitis is a budding yeast called Cryptococcus. And this puppy is encapsulated, and that India ink will reveal a budding yeast. This thing usually causes pneumonia first. Usually the pneumonia is the symptoms are not very robust, usually asymptomatic. Then it will spread, get into the bloodstream, spread to the blood, the brain. This organism has a predilection for the brain. So that is another feature that we can get. All right, so the Neisseria meningitidis, this is a gram-negative Diplococcus. It causes a very serious acute meningitis. Because young children don't tolerate the vaccine because the vaccine is mainly carbohydrate, vaccination is not recommended until a little older age. So young children, if they get this, it tends to be quite severe. There's several different capsule types. These three are the ones responsible for most of the infections. Consequently, your vaccine tends to cover most of those strains. The organism gets acquired usually through the nasal cavities. This petechial rash I told you about, if that looks pretty severe, that's because it is. The organism also makes an immunoglobulin A protease that takes secretory protease that might be made in the nasal cavity and clips it in half, so it can't affect the organism. The organism also does this other weirdo thing. So it attaches by means of pili and by means of a surface protein called the opacity protein, which is also called OPA. Turns out that in the organism, you have the promoter and then the genes that encode these. There are these cassettes of genes. So this would be, say, pili genes, these would be opacity genes. The organism can swap in one or the other at certain times. So the organism, your immune system, will make an immune response to this pilus. Then it swaps in this other coding region for the pilus. Now your immune system goes, hey, what's that? I've not seen that before. It has to remake an immune system against that pilus. Does the same thing with the opacity protein. It attaches to the mucosae through the pilus and the opacity protein. But because the organism varies these genetically, it keeps your immune system guessing. The meningococcemia that it causes has high mortality rate. It's a very fulminant disease. The disease comes rather suddenly. The fever is very high. There may be some other symptoms that you see here, the bleeding under the skin. That's really common. And that's also diagnostic for Neisseria meningitidis. Because of the release of lipopolysaccharide throughout the bloodstream, you can get DIC, disseminated intravascular coagulation. That uses up all the clotting factors and then causes massive bleeding all over the body. One of the things you can see with this organism is hemorrhage in the adrenal glands. That's called Friedrichsen-Waterhouse syndrome. Friedrichsen-Waterhouse syndrome. That's a hemorrhaging in the adrenal glands, usually due to using up all the clotting factors. That will cause a complete and total collapse of the adrenal pituitary axis. And that's your damage to the adrenal glands. That will cause death very quickly. Of course, shock is also very common too because of the bleeding. Neisseria, as you're going to discover on Wednesday, are hard to grow in the laboratory. They like 5% carbon dioxide, so you have to grow them in a gas pack. They're also really picky about the media on which they grow. So you use either chocolate agar or use this stuff called Thayer Martin agar to grow them. They're only found in humans. I'm not aware of an animal reservoir. It's usually humans. Consequently, if you live in close quarters, so military barracks, college dorms, daycare centers, families, so on and so forth, it can get passed pretty quickly. It's passed through respiratory secretions. Highest risk, of course, are younger children, children who have not been vaccinated, younger adults who have not been vaccinated. Diagnosis is usually with a culture. Serology is not much help. There are serological tests. Culture is usually faster. There is a PCR test for this so instead of waiting for the organism to grow on culture, you can do a PCR test, which is much faster. These organisms are oxidase positive, unlike other gram-negative cocci. That is a feature of these organisms. And you usually treat with ceftriaxone Remember, in babies, you can't use ceftriaxone. You'll use cefotaxime instead. The ceftriaxone causes biliary sledging. Books keep saying to use high dose penicillin G. That's only if your organism is susceptible to penicillin G. To do that, you'd have to culture it and then do susceptibility testing. By then, your patient will be dead. So penicillin G is usually not used. Only the susceptibility of strains to penicillin G varies geographically. Here in Michigan, it's something like 30% of strains are susceptible to penicillin G. So nobody uses penicillin G. They all use ceftriaxone. The ceftriaxone, IM shot, you're one and done. You don't have to worry about it. Penicillin G has a short half-life. You have to keep giving it penicillin G intravenously, and it's, yeah, bigger pain. Preventative therapy with rifampin is used. So say someone in the family has Neisseria meningitis, you isolate them, and then you can give the other members of the family rifampin prophylactically. Remember, the big thing about rifampin is it turns secretions orange. So the pee's going to be orange, the sweat's going to be orange. They have contact lenses, it'll stain the contact lens orange because of its tears. They have to up their cleaning regimen with contact lenses. And that's the thing to worry about with rifampin. Strep pneumoniae, again, usually you have an upper respiratory infection first. And then the passage through the blood-brain barrier occurs via hematogenous spread. Very frequent cause of community-acquired meningitis. Here you have diplococci, but these are gram-positive cells. Capsulated. The organism also makes a hemolysin. Officially penetrates via the respiratory mucosa, gains access to the bloodstream, and then gets through. It's able, actually, it has a series of proteins that attach to phosphocholine. The cells in the blood-brain barrier are loaded with phosphocholine. It binds and then it is phagocytosed by the cells of the choroid plexus, and then it gains access to the meninges that way. Penicillin is not a good choice for strep pneumoniae. So it's usually vancomycin ceftriaxone that will be used. Fortunately, they're good vaccines for this organism, and I'm going to guess that a lot of you probably had this when you were little. The Pneumovax 23 is for adults. The 13 is for childhood immunizations, and I know some schools require it. I don't know if all schools do. I know Western schools here in Michigan does. Other schools, other states, I'm not so sure. Haemophilus influenzae, it's usually the B strain. That will be the culprit here. Consequently, the vaccine is against the B strain. Still an important cause of meningitis in kids under 5. Once you get past 5, it's usually not much of an issue. This is also an encapsulated organism with a polysaccharide capsule. Gains access usually through that nasal cavity. Does not usually cause a previous disease, but it can. Fortunately, the organism is very treatable with ceftriaxone. All right, we'll talk about listeria on the other side of the break. So we'll take 5 and then we will get to listeria. As he's trying to use the Zoom and she can't get onto Zoom either. I tried to set the Zoom up last night so that you guys would have the link last night, and I couldn't get it to set up either. Only when I came in this morning was it mysteriously working. Had to do that today. Started. Up here.
Yes, we actually first meet.
Ready? Right, I think our 5 minutes are up. Okay, let's continue then. Listeria monocytogenes again. This one's foodborne. Foodborne. So it's gram-positive. You tend to get kind of shortish looking rods with Listeria. The organism is flagella on either side of the cell. So in culture, you get something called tumbling sort of motility. It tumbles because it kind of goes. Like my daughter and son-in-law's puppy. It doesn't go straight line, it kind of goes like this. So I think instead of naming it Chylo, they should name it Listeria because of the way it moves essentially. So it has a tumbling movement in culture. The organism usually infects the mucosae of the GI tract. It then co-opts the cytoskeleton of the cell, and it causes the cytoskeleton of the cell to push it around the cell, and it can push it to the next cell even. So it can spread from one cell to another very quickly, and it can get shed into the bloodstream, and it can go to the blood-brain barrier as well. This organism is resistant to cold, heat, salt, pH extremes, and bile. Consequently, salting food will not kill it. That's why deli meats that are preserved with salts, benzoates, or something like that, that won't stop this organism. The beauty is that you can grow it on dirt near anything if you want. But it tends to grow inside the cell. It grows inside the cell. Can survive also inside phagocytes as well. It secretes a variety of proteins that take the phagosome and harden it, prevent it from fusing with the lysosome, and now it essentially gets preserved inside that hardened phagosome, if you will. Usually in a healthy individual, you get a self-limited diarrhea or fever or sore throat. In the elderly, you will tend to get a meningitis, or in neonates or in born. In this case, it can also cause a bacterial septicemia. And as you can see, the mortality rate is about 30%. So this is not an infection that you can mess with. And remember, crosses the placenta, infects the unborn, and this may cause premature abortion and fetal death in some cases. The organism is found in soil and water. It does infect certain types of animals secondarily. So you get it through ingesting contaminated dairy, poultry, meat, things like that. You get it in chicken, you get it in lunch meats, hot dogs, cheeses. The big ones in California, of course, were surrounded Altadena dairies. Jalisco cheese. Jalisco cheese was contaminated with Listeria, caused a Listeria outbreak in Southern California. They got their dairy from Altadena Dairy, and Altadena Dairy and notorious essentially as a source of listeriosis in many cases. They got shut down. You can cold enrich for this organism. So you can take the organism and culture it at 4 degrees. Many of the organisms that like warm-blooded critters aren't going to survive. Listeria can. So that's one way essentially you can use to isolate the organism. There are rapid diagnostic kits. These work very well. There are also good immunofluorescence and PCR tests that are available for detecting this organism. Remember, when treating this organism, you can't use cephalosporins, you have to use ampicillin. Sulfa drugs are your second tier, essentially. Third tier would be gentamicin. Gentamicin, remember, is an aminoglycoside. You want to be careful with that drug, and kidneys and ears with that one. So, food should be properly washed and prepared properly. Pregnant women should be cautioned not to eat soft cheeses. Think of soft cheeses, things like brie, things like, what's that other spread cheese? Got a French name, I can't remember. Shouldn't eat that either, whatever the name of it is, I can't remember. Feta. Feta is not really a spread cheese, but that's one you should stay away from when you're pregnant. And it's a marmalade type cheese. I can't remember the name of it. Oh, brioche. Brioche, that's the other one. The other one. So Cryptococcus neoformans is a fungus. It's a filamentous fungus, but when you inhale it, the filaments transform into a yeast. This is associated typically with bird dung. Bird dung. Pigeons, bats aren't birds, but their dung can contain this organism. Because that dung can dry, and the dried dung contains the organism that can be wafted in the air, you can inhale it. In most people, the organism is usually dealt with by the alveolar macrophages. You have absolutely completely asymptomatic infection. In some people, then you may get some sort of pneumonia, and usually it doesn't go very far from there. But in people who are immunosuppressed, so people with HIV/AIDS, who are organ transplant patients, this can now spread to the brain. It can not just cause meningitis, it can cause meningoencephalitis. If you try to culture it on bacterial media, you'll usually get molds. People will throw them away and say, oh, my plates got contaminated with mold. So India ink is one of the best ways to detect this. The organism makes a very robust capsule, as you can see. That capsule is highly antiphagocytic. The organism also possesses a phenolic oxidase system. Phenolic oxidase system, what the heck is that? The organism has a predilection for the brain because it likes phenol-containing compounds. One of the ways you can identify this organism, in fact, we did a little project when I was in graduate school. The water tower at Mirac Hall was infested with pigeons. So we donned our PPE and our masks and our Darth Vader suits, and we cultured the pigeon dung looking for Cryptococcus. The medium we used to detect it was birdseed agar, because birdseed agar contains phenolics. When this organism grows on birdseed agar, it makes a really dark colony, because it takes the phenolics in the birdseed and oxidizes them, and it makes these dark compounds. Where in your body do you have the most phenolics? In your brain. Your brain's full of neurotransmitters that are all phenolic compounds. So the organism has a predilection for the brain. That's why it goes to the brain. It can charge right through the blood-brain barrier. It makes metalloproteases that just degrade the blood-brain barrier, and it goes right through. Healthy humans, usually it's not a big deal. But if you have people with compromised immune systems of any sort of inherited immunodeficiency that we talked about, chronic granulomatous disease, organ transplants, HIV/AIDS, any sort of complement defect, any sort of antibody producing defect, A-gamma globulinemia, something like that, they are susceptible to meningitis by this organism. In AIDS patients, it's frequently fatal. Also, people being treated with steroids, uncontrolled diabetics, and cancer patients also are susceptible to meningitis. So this organism you're going to treat usually with amphotericin B. Amphotericin B usually has to be given intracisternally. So you have to stick a needle into the fourth ventricle and provide the amphotericin B that way. You will also add usually cytosine. You can use fluconazole for the pneumonia. Fluconazole does not penetrate the blood-brain barrier. So in this case, flucytosine plus amphotericin B is your drug of choice. Never use flucytosine by itself. Never, never, never. That combination will usually kill the organism quite well. Coccidioides immitis usually causes a respiratory infection, but in certain people, who are genetically predisposed to disseminated disease, it can spread really to any organ. And one of the organs it can spread to is the brain. So the organism in the soil makes these arthrospores, arthrochondria, like little trains that fill off a train track. Inside the organism, when you breathe them in, the arthrochondria round up and become a spherule. This thing is spherical and divides by progressive cleavage. And many people get it, and it's just not an infection that causes any symptoms. Other people will get a nasty pneumonia that may knock them on the back for 6 weeks. And in others, it can actually spread. And there is an ethnic tendency for it to spread in certain populations. So American Indian populations, unfortunately, African American populations, they have a higher predilection to spread. Also, people with suppressed immune systems. In the pneumonia stage, fluconazole works very well as a treatment. Once it gets to the brain, you start to need to use amphotericin B. I have to warn you, this is a very toxic drug. So that's usually only used if the patient usually gets very, very sick. And you have to give it intracisternally. And it's very hard on the kidneys. Usually you're going to want to sodium load the patient to protect the kidneys. That will usually protect the kidneys. Also, there are liposomal versions of this. They're packaged into liposomes. They're not nearly as toxic as the straight doxycholate salt. If you see the spherule in tissue, it's coccidioides. It's nothing else makes it spherule. This organism likes dry alkaline soils, like the kind seen in the Pacific Southwest. So California, Nevada, Arizona, parts of New Mexico. It's not in Michigan. It's not dry and hot enough here, like desert environments, essentially. I did my master's thesis on this organism. So this organism will always have a certain place in my heart, I suppose. They call it San Joaquin Valley fever. Yeah. All right, viruses. So meningitis caused by viruses, usually in children, main culprit will be your enteroviruses. Oh, but wait a minute. It says enteroviruses. I thought those caused, like a stomach flu sort of thing. Yeah, they do. And they also cause meningitis. There are really three subgroups. So they're the so-called echoviruses. And then Coxsackie virus. There's another called the PAR echo virus group. These cause most of your meningitis infections in children, usually self-limiting. Usually not an issue. Now, some of these, if they infect kids before the age of 3 months, then they can cause pretty serious infections in the kids. And it may leave the kid with some sort of palsy or something like that afterwards, but not always. These are passed through contaminated food and water. Food, water, and fingers. So what's a good way to avoid getting these viruses, you think? Oh, there, you look down at your hands, you start washing your hands, you start doing that. So the answer is cleaning, hand hygiene. Hand hygiene can avoid most of these infections because of the way they're passed. Other meningitis infections are with HSV2. In this case, usually mom has a genital infection. It's passed to the baby. And in that case, then it causes a very serious meningoencephalitis. If mom has an HSV2 genital infection, can she still have a baby? Yeah. Fortunately, the antivirals for HSV2 are completely safe during pregnancy. So acyclovir, valacyclovir, gencyclovir, those drugs, very safe. And if you give them, they can suppress the virus and prevent the baby from being infected with HSV2. Other viruses that can access the nervous system will include things like mumps virus, measles virus, and then, of course, polio. Polio is also a member of the picornavirus group. Poliovirus is very stable in large bodies of water. And so usually you get this from water. Most of the kids who get it, that's why it was called the summer flu. Most kids, when it would warm up and the ponds would melt, would in the summer go swimming. That's when they usually got polio. So it's usually water, it's ingested into the GI tract. %90 of people who get polio have an infection of the gastroenteritis, gastrointestinal tract, and they don't even know it. Doesn't usually cause many symptoms. Others of those 10% who get symptoms, probably about 9 out of 10 of them will usually get some sort of diarrhea or something like that. Out of that 10%, 1% of that 10% will usually have the virus infect the motor nerves that cause the stomach to churn and mix and what have you. So then the virus then retrograde. The retrograde infection will make its way into the cell bodies in the spinal cord. And by destroying the motor nerves in the spinal cord, they will cause usually unilateral, mostly unilateral, but sometimes bilateral paralysis. People who've had polio will tend to have usually some sort of paralysis, usually on one side, and then they walk with, some sort of rolling gait like that. Bilateral paralysis is not nearly as common, but it does occur. And in cases like that, usually there's paralysis of the whole lower part of the body. Have you read any biographies of FDR? So FDR had polio as a kid. He had bilateral paralysis. Many times when he would speak, he did a lot of his talking on the radio. He did the radio chats, but when he spoke in public, his legs were braced. And he often went to these hot springs. These hot springs, essentially, the heat would relax his overly tense muscles, and he'd be able to walk a little bit, but later on in life, he was restricted to a wheelchair. Bulbar poliomyelitis, bulbar, involves infection of the cranial nerves. And in cases like that, there may be issues of swallowing, speaking. And in some cases, if you have paralysis of the phrenic nerve, then you have to spend the rest of your life in an iron lung that does the breathing for you, essentially. That's what an iron lung is for. Have you ever seen an iron lung? So during the animal rights protests at UC Davis, we wheeled an iron lung through campus, and we put a sign on that says, be thankful for animal research that you don't have to spend the rest of your life in one of these. And we got jeered, and I got lots of hate mail from it. It was just wonderful. I just loved it. Iron lungs are big, bulky, ponderous things, and you spend the rest of your life paralyzed, flat on your back, essentially, because of polio. Mortality rate is very low. Usually resolves within 2 weeks. Won't usually find anything in the CSF. Viral culture is not used as much. It's usually serology or PCR tests that will be used. In cases, usually no treatment is needed. There's not a lot of evidence that treatment usually works. One thing I forgot to mention. With bacterial meningitis, when you treat, and the handout I gave you shows you the antibiotics. When the antibiotics kill off the organisms explode, and they provide all this material now in the CSF for increased inflammation. That increased inflammation can leave the patient with neural deficits. Turns out, if you treat and you add steroids with bacterial meningitis, you don't tend to get these sequelae. There's no evidence that steroids work for viral meningitis, but for bacterial meningitis, you give the drugs plus steroids. And the steroids prevent this excess inflammation while the bacteria is being killed. And that excess inflammation is essentially what might cause an issue. Okay. Talked about this, neonatal meningitis, strep eagleocti, again, very susceptible to ampicillin, penicillin, amoxicillin. Do a vaginal swab usually week 35. If she has strep eagleocti, you treat. If the baby is more infected, intravenous antibiotics, penicillin G, it's usually the drug of choice, and there's usually not much to say about that. Usually, E. coli, this organism is getting harder and harder to treat. Strains are resistant to lots of bacteria. Unfortunately, it's aggressive if it does appear in neonates. And you treat usually with this type of combination, ceftazidime, cefepime, plus or minus gentamicin, depending on the strain. Those are given intravenously. Monobacter. Do you guys remember during COVID, there was the baby formula plant that was shut down in Michigan? Because it was contaminated with Chronobacter. Chronobacter contaminates dehydrated baby formula. That's how the organism is passed into babies. It infects the GI tract, then through hematogenous spread, it spreads to the brain. And it can cause neonatal meningitis. So, because of this, there's been a lot more stringent testing now of formula. That's how you get this Chronobacter organism. Sakazaki, it used to be called an Enterobacter. It is a member Gamma proteobacteria, the same group as E. coli, Shigella, Salmonella, Proteus, and so forth. But you get it essentially, it's very resistant to desiccation. So when you freeze dry the baby formula, it survives. So that's Chronobacter. The CDC page for Chronobacter is in on our website. You can read about it. And then Zika virus. So Zika virus is passed by mosquitoes. It's a member of the flavivirus group. Doesn't cause a very robust disease in humans. But number one, it reservoirs in animals. Number two, if a mom who's pregnant is infected with Zika, it can cross the blood-brain barrier, it affects the neuroblasts in the brain, and it kills off the neuroblasts, so the kid is born with microcephaly. Oh, it's this congenital Zika virus syndrome that is the issue. And mom will not remember any infection. She won't even remember getting bitten by a mosquito usually. So in areas where Zika virus is an issue, mothers are advised to stay indoors and use insect repellent. And plenty of insect repellents are resistant, are safe essentially for mom and baby. Say most infections are asymptomatic. It says it's transmitted by Aedes mosquitoes. It's actually transmitted by a couple of species of mosquitoes. There's no vaccine available, but Moderna is working on a messenger RNA vaccine for it. So kind of watch this space on that one. Talked about polio. This is the last thing we'll have time for. So primary amoebic meningoencephalitis, or PAM. Primary amoebic meningoencephalitis is caused by these two amoebas, freshwater amoebas. The big one is Naegleria fowleri. If people swim in stagnant, warm ponds, and as they dive in the water shoots up their nose, these organisms can move through the cribriform plate. They get into the brain, and they cause this very fulminant meningoencephalitis that can kill you in 2 to 3 days. The organism is not easy to treat. Really, the only way to see it is to take the CSF, and you can see the amoebas, usually in the CSF. The organism makes a variety of proteases that degrade tissue. It kills off a lot of brain cells. It can cause hemorrhage and coma, death within a week. As a result, essentially, you're just advised to stay away from swimming in warm, stagnant water during the summer months. It advances so rapidly that treatment is often futile. Amphotericin B is usually the drug of choice to treat it. Sulfadiazine might be of some benefit, but essentially, if you have public swimming pools, chlorinating them is the best way to avoid it. So just avoid swimming in warm, stagnant pools. Okay, we're almost done with this. We'll finish this on Friday and get into respiratory infections.